I guess so.
Hi.
Mhm.
All right.
Okay.
Well, welcome everybody. We're really happy to have this topic and have all of you guys joining us tonight. Our guests this week are Dr. Robert Druker. He's a psychiatrist working for the Wisconsin Department of Corrections and for the MICA program. You'll have to tell us more about that. But it's a dual diagnosis program for inmates with severe mental illness and substance abuse disorders.
Correct.
Yeah. And then we have Dr. Robin Goldberg, and she's a psychoanalyst. And she works with us at Centerpoint for Children in our suites, and she reminds us all the time of the emotional well-being of our clients and what's needed there. And hopefully Courtney Lindblom, who is a marriage and family therapist and a psychotherapist, she will be joining us hopefully as soon as possible. But our topic this week is really timely given the social climate with COVID-19 and Black Lives Matter protests that are going on right now. Hi, Courtney, there she is. You're muted. If you want to unmute. Okay, you're fine. All right. So I just wanted to start because I was thinking about this all week, that it was so timely that the current discussions about reimagining funding, particularly in vulnerable and minority communities, the need for increased support to mental health and drug addiction, and a move away from punitive measures. And we're very supportive about that. So maybe Courtney, hi, I gave a little introduction of you. Let me make sure I got it right. You're a marriage and family therapist and a psychotherapist and work with us at Centerpoint for Children. Yeah? Okay. Hello.
Don't forget our toast, Susanne, because
That's
we
right,
need the toast.
Marco. And before we get started, we do want to toast.
Cheers.
Yes. Cheers. Cheers.
All right.
Cheers, everyone around the world.
Cheers.
Yeah, our idea was that these webinars would allow us to stay socially connected while we physically distance. I'd actually like to start, Bob, with you and talk a little bit about how you decided to move into psychiatry, because you have a bachelor's and a master's degree in occupational therapy. And you were able to study directly with Dr. Ayers in the OT 610 4-month clinical training program. Right?
Correct.
Yeah. So tell us a little bit about you.
Well, all right. I guess the story with me was that, I came out to Los Angeles to train with Jean, and that would have been, I believe, 1977. And but I had met her, in 75, I think. She had come out. That was on the days that she was teaching the courses herself with a few other people. And I volunteered from the audience to be one of the kids when she was demonstrating tests. I still remember she was demonstrating what was it called then, right-left discrimination test. And it was that thing, take this pencil in whatever hand and then put it back in what was it? And she held out her hands, and I took the pencil and I laid it so it was in both of her hands. I laid it across like that. I wasn't trying to be a smart, I was just trying to confound. And she just gave me this look. It was the first time, if you've never looked into Jean Ayers' eyes before, it was just so deep and piercing. And I just thought, right then, I want to work with her. How's that going to happen? And that was 2 years before she started taking trainees.
Uh-huh.
But over time, when I left Los Angeles, I went and worked. I'm from Iowa originally, and I came back and was working in the University of Iowa Hospital with an autistic children's program. And there were so many doctors around, and I had really, really always wanted to be a doctor. That was just sort of my destiny. And it just emerged that pull started on me again, and it was impossible not to be pulled that way. It's hard to say all the reasons, that we do things.
Yeah.
You don't really know at the time. You think, people ask for an explanation. You say, well, I'm doing this because of this and this. And 40 years later, you may begin to understand now why you did it, because you know yourself in a different way. But I always felt that there would come a time that I'd be able to, be more in the fold again with OTs and SI. Jean, went on to pass away way ahead of her time and disrupted my little fantasy of staying, because she took it a little bit personally. She was never treated well by the field of medicine as a whole. So I was it kind of triggered defect, like a defector kind of thing in her. We worked through it, fortunately, before she passed away.
Well, and Bob, I don't know if everyone knows about your work on the test that you developed in your master's program while you were still in OT, but I wonder if you could talk a little bit about that, since it's really come full circle now with the EASY.
That is part of the full circle. When I stayed at USC and got my master's degree, it was a thesis program. And I did as a thesis the development of a thing called the FIPIT, the finger position imitation test. And the FIPIT was designed to be for older children than the SC-SIT was for. That tended to cut off, 4 to 8 years old or something like that. And you could use it from 9 till 10, but you were extrapolating. So my test was for older children, and by definition, adults, really, because what I found out was there wasn't much change in the scores, at least, of adults compared to 14 and 15-year-olds. But right when I finished developing it and finished my thesis, that's when I was able to get into medical school. And so actually I'm looking right over there, there's a box where everything is still there. All of the test sheets, the computer printout. You remember what computer printouts used to look like, these scrolls of things. So that's funny, it's sitting right there. And Zoe was able to take some of the stimulus items from the FIPIT and use them in your current test, which is called
The EASY.
The EASY.
The EASY, the evaluation in neurosensory integration, which we are going to have a session on in the next few weeks. But yeah, it was, because we wanted the EASY, as we were developing the new test, we wanted them to go across a larger age range, including older ages. And we thought about you in the Fitbit, and it was so generous of you to share the best items. And so I just sent Bob the test sheet today showing them the items that we ended up with. And I think quite a few of the Fitbit items are the hand items.
Seven or eight of those postures. I mean, I looked at them and I went, oh my gosh, she was able to use them. That was so cool.
And that means they were the strongest ones, because we chose items based on our analyses and we picked the best ones. So anyway, it is really amazing just how life brings us together. We go and do our things, and then we kind of find our ways back. It's really fun.
But you'll appreciate this. Zoe had to search the world to make sure that none of these symbols that she had created meant something that we didn't know. And actually, there were a couple that people said, "Oh no, not that." Yeah.
That was fun. We did find out about the Merkel stance, that Angela Merkel stance, which she tries to show calmness and power at the same time. That was an item. So.
Well, one of the things that I always wondered, even went back in the 70s when I was learning about sensory integration, is if we identify these kids with some of these issues early, could we keep them out of the system? And now you're working with adults in prison that clearly ended up having trouble. And what do you think about that? I mean, do you think we can prevent? some of it? Any of it?
Prevent final outcomes like that, you mean?
Prevent people ending up in prison with severe mental illness and incarceration.
I think to a degree, I think that the communities that are traumatized and where people's early experience is affected so badly, you know, through everything, and Robin and Courtney can probably speak to it better than I can. But there's so many things that open you up for either doing bad behavior or getting into drugs. And obviously we know that there are a lot of neurological, you know, moderate neurological things that are never identified. But I think that there are just so many things that set people up for bad courses in life, you know, and they all have to be looked at. I mean, everything's important.
Well, maybe that's a good entree into talking more with Robin and Courtney about your practices. And maybe Robin, could we start and tell us a little bit?
Yeah, the way I got started, I'd actually been in another field. I had been in the field of theater, so I worked in theater with children, and I began to train as a psychoanalyst. And one of the members of my cohort group was a speech and language therapist for early childhood. So he worked with 0 to 3. And he enticed me into becoming a part of a program in a very poor school district where he worked. They had a 0 to 3 program as part of the school district. And it was anybody could be identified, self-identified or identified by somebody professional. And the exciting thing about this program, it was a model program in the state of California, and who knew it was in this little school district. We were a team, and the members of the team were pediatric speech and language, pediatric physical therapy, special ed teachers, pediatric OTs, an anthropologist, a linguist, and members of the community who may or may not have graduated high school, but they were the aides. And we worked as a team, a co-equal team. And what was most exciting is that the children identified who they were going to attach to because it was goodness of fit. And from all of these different perspectives, we would work with the children. And we had 2 models. 3 days a week, there would be a drop-off model where the parents would drop the children off. And they had a range of difficulties. Just had to be a child that had difficulties. 2 days a week, the program was for dyads, a caregiver and the child themselves. And we would begin to work from all these different perspectives with the children. And what was exciting for me is of the first 4 children that I was focused on as my kids, or they found me, 4 of them, of the first 4, they all had really strong sensory issues, sensory defensiveness. Some of them had other kinds of physical issues. They all looked severe, and you would place them on the autistic spectrum. Of those 4, only 1 remained on the autistic spectrum after the early intervention. The other 3 were trauma. But of course, what we were working with was what we call bottom up. Top down would be play or talk, but they weren't ready for play or talk. So we all worked bottom up with them as a team and worked with the moms and the infants to help them attune. So this was life-changing for me, because it was from this experience that I really knew that when I set up a private practice, it was going to have to be a practice that incorporated multiple disciplines.
Well, I'm really glad you did that. we're really benefiting from that.
And then I had the good luck to meet Susie Greenwood, who was working with a patient that had also come to me. And through that experience, we began to co-treat. So in the co-treating, Susie might work with the child for the first half hour to give the child the best regulation possible and to get her ready for my interventions. My interventions might take place in the OT gym where she continued on the swing, and I could then begin the kind of work that I could do with her. And we would co-treat during that time, and then we might continue and finish the session with me and the child, or with me and the child and the mom, depending on the right treatment plan. In my private consulting room, it's always good to have a good OT in your ear who can help understand, oh, this child, they're just kind of melting on the chair. Well, we need some postural control, but to keep the child aroused, maybe you need to have a bouncing ball. So I learned to begin to see and reframe things with the OT in my ear helping me, as I would help the OT show the way that this experience of the body in the world was affecting the child's development of their sense of self and of their relationships.
Mm-hmm. That's really great.
So I really think you set the child's life on a different track and the parent's life on a different track.
And you're talking about a pretty large range of abilities with the clientele, right?
Absolutely.
Yeah.
Absolutely. And the other thing can happen too, where there's a parent with an undiagnosed sensory issue, and they might have a spirited child, and they bring the spirited child in as the problem. And what you kind of discover is that the parent has an irritability that they haven't known about. And so that they can't tolerate the spiritedness of the child. And really, what is psychotherapy? Psychotherapy is trying to help somebody know something true about themselves. And something true about themselves is also the way your body is in the world.
I love that definition.
That's a good quote. We get a lot of great quotes out of these sessions. We really should make sure we capture all of them.
Robin, we just had a question regarding to that early work you were doing in the school district. Liz is asking if there was any differences between the child parent group and drop off. I don't know if it was the same group and just different days. Can you just tell us a little bit more about that?
So some chose just to come 2 days a week. It could be the child and the parent, but sometimes the parent's working. So it could be an aunt or a caregiver. And sometimes they'd come 5 days a week. There'd be drop-off days, and there'd be days with the parents. So it really depended on how they wanted to work the program. Mm-hmm. The school district was really, I think, really so forward-looking.
Mm-hmm. And did you guys gather any data on differences on these two groups?
We weren't gathering data. I can tell you impressions-wise. You have two things. So those who came from families that were organized enough to be able to have a caregiver come in is already a family that's got a little bit more strength to them. So there's that factor. But you could also really see the change in the parent and the child relationship coming in.
I do. It's interesting because I'm enrolled in a project in an hospital. It's similar like that. And parents, and it's with babies from 2 months old, and we follow the babies every month. It's not so routinely, it's not every day, but we see them coming every month, and we see the difference, not only on babies with some, cues that we can give them so parents can bring home and do with them, but on parents' perspective. And this is low-income families and a lot of drugs, a lot of, and it's amazing the difference that only this little bit, it's like once a month, and it's crazy. It's great, the difference, the impact. Yeah. Thank you.
And it's so important for parents, if they can read the cues of their children better, they feel like better parents instead of feeling hopeless or I'm no good at this or angry at the baby.
And then it's a cycle, isn't it?
It's a cycle. Yes.
Yeah. Thank you.
Yeah, so I think we've gotten better as a team with parents as partners, you know, with having families much closer to the treatment, maybe within the treatment, or just having a lot more dialogue with the families. Following assessment, of course, we need more assessments for adults, for sure. As Bob noticed, you noted we don't have too many. But Courtney, maybe you can tell us a little bit about how you're working as well.
Sure. I think my start was maybe kind of the opposite as Robin. I started out as a research assistant at UCLA studying efficacious treatments for kids with anxiety and depression, which is a very like cognitive model rather than body-based, you know, top down maybe. I learned a lot from him. He now runs the Harvard Child Study Center. I was lucky to be underneath him. But my real work and where I learned the most would be from my colleagues really at Centerpoint, including Robin and Susanne and Susie and Aparna and all the OTs there, because of how it's taught me to really integrate body into everything that I see, even as a form, an expressive form of communication, right? When we see a kid who's dysregulated, what does that behavior mean, right? And it depends on what model you're trained on, but I think kind of attesting to what Robin's saying, if you can read your child's cues, parents feel like better parents, right? They start to have some tools in terms of how to help them. Where if you see that as a misbehavior or, you know, something that's oppositional or defiant, your relationship with that child is kind of forever shifted. So, you know, I've been beyond grateful for that work. I too got to work on a team, and I was really trained as a very young therapist from that Stanley Greenspan model early on. So, you know, psychoanalyst Robin participated in that team, and Susanne Greenwood, and speech and language pathologist. And I love the fact that as a more seasoned therapist, I can utilize different lenses to see kind of the same problem. And the inclusiveness of the family and how that makes sense developmentally, right? Where if you traditionally in psychotherapy, you might drop your kid off at the office and they go in and they see their therapist and the door shuts. And maybe you'd get little pieces of information here or there because, you know, I of course still honor privacy, but what you're doing with a young child is not really working to improve their relationship with their caregiver, right? And, you know, the strength and co-regulation and attachment and what you gain from that has really changed the way that I work. I too am lucky enough to have my kids sometimes go to OT first. I think that's a tremendous value for my kids that are either under aroused that kind of need to come up to maybe more of like a green zone, or the opposite. My kids who are quite hyperactive get some regulatory tools before they come in and see me. And what I notice after, especially with my hyperactive kids or my kids who are moving all over the place, when they come to me in a calm and regulated space, I get more access to their internal world. They're either able to communicate that to me more accurately, they're able to kind of acknowledge that within themselves and really notice and pay attention to it. They have more access to their play. You know, I'll be on the floor with them. I borrow stuff from the gym, thanks to, you know, all you lovely people, and things in my office. So I have a trampoline in my office. I have a heavy weighted pillows, kind of whatever it takes to give the child that physical support. And what it's done for me is allow a lot more psychological access. So even though I started maybe from more of a cognitive model, I've certainly shifted to more integrative. I love including the body and the OT tools that I've learned over the years. I think it's done nothing but make me a much more successful therapist. And then including family. So that's a little bit, like a little snapshot, I guess, of where I came from and where I am and what genres I borrow from.
I think one of the things that we love about the OTs that are part of the Centerpoint family is that they all understand relationship, and they understand natural play, and they understand development in a natural way, so that we're really just working so beautifully together to integrate that and to join the children. so that we're not in the work of forcing, but we're in the work of creating the conditions under which the movement and the development will take place.
I really like how you're describing this. At the International Sensory Integration Congress in Hong Kong, I did a little talk, and my proposal was that we could possibly in the future get away from either or, like the top down, bottom up, as you guys are describing, and rather adopt a transactional model between bottom up, top down, going back and forth between the two, because I don't think either one is going to be the ticket for every child. Sometimes you're going to need one or the other, but I think both and meeting in the middle. And so I think that that's at least where I hope we're headed with sensory integration theory and practice, and ROT is in the transactional area, not impairment based, not, we're not coming from an impairment model. It's a transactional model.
Yeah, I'm wondering if Bob maybe can comment on some of these themes about family and, since you've been working with adults on the other end of the spectrum, and I know we were interested in how much your background in OT and sensory integration maybe has influenced the way that you see your work and interact with your patients.
I think I'll comment on something, but I think I'm going to derail your question a little bit and pick up on something that Robin had said, which kind of caught my ear because it relates to the musical play that I was working on, and I wanted to make sure I had a chance to talk about. Would that be okay if I just switched?
Absolutely.
This is a fun free for all. You just talk about
dive in. The whole that formality is just to get us going.
What I really wanted to say to the panelists, of course, but to the people watching who are who work with children and are leaders in your fields. The thing that I've been doing over the last couple of years and intensively over the last couple of months when I've been home on the stay-at-home was finishing a musical play that I was working on. And when we went to a shelter-at-home kind of situation here in Wisconsin, my cast was just about to go into a studio and record all the songs for the script, which was a theatrical play. And I thought, in the middle of every difficulty, there's some kind of opportunity. Why don't we just record the whole play and release it as a radio play serially? And so that's what we're doing. And the overriding theme of the play is really truth, as it turns out. And it's a fantasy, it's a fairy tale in a world where dogs and cats can talk, and an occasional plane and train can talk, but it's not for 3 to 5 year olds. It's for, I don't know for sure, second grade and up, I suppose. But it has several characters who've been traumatized in ways that keep them from their own inner truths. And there's one character who has, we didn't use addiction language, but there's one character who has a use problem, let's say, the train. And there's a dog that's been traumatized, and there's a little plane that's depressed, but all of them aren't themselves, that they're blocked from their own true selves by some kind of adverse condition that they have to overcome in the course of this heroic quest, which is a quest to bring back something that's going to thwart an evil king that's threatening them. And what we did when I realized that this opportunity was forthcoming to talk to a lot of people, we put the play up on a website called soundcloud.com, and it's up for free. It's not monetized, and so it would be. And I think Katie's going to put the link to it.
We are working on that right now.
So what I wanted to say, really, and I know it sounds like self-promotion, but there's no money in it. The promotion, I think it could really be well received and helpful to children and possibly to the world at large right now, which I see as being in a great deal of distress in a lot of different ways. And I feel strongly that Gene Ayers would want me to use this opportunity to call attention to it, or I wouldn't be doing that. So I'm hopeful that people could take a listen to it and share it to the degree they feel they want to.
Thank you, Bob. And we just shared on the chat box so everybody can take a look. It's really interesting. Thank you.
We're going to be posting one episode a week for 6 weeks and kind of running with it.
Well, I got to listen to it today. It's utterly charming, engaging, and at the end I was like, but wait, the story, it's not done. What's next? And I'm once a week. I have to wait once a week, but I'm for sure going to be watching that.
Thank you.
It's delightful.
It's interesting that both you and Robin have some background in performance art.
Yeah, yeah, it is.
We like to play, and I think that when a session is playful, then whether it's a child or an adolescent or an adult, there's an openness to what's happening, and there's a flexibility in real play.
Yeah.
Well,
Have you used your music or your writing at all, Bob, with the adults?
Not really. There hasn't really been an opportunity to do that with the adults. I mean, writing the songs for the play, which I think would be enjoyed by adults. My thought was it would be something that parents would enjoy too. But I don't do much. I don't do any music, in the corrections job. Yep, none. Yeah.
well, I would love to have a little conversation with all of you guys about trauma, because I think many of the children and families that come to us, whether it's explicit or not, have experienced trauma that kind of goes under the radar, or we're dealing with cultures who aren't really comfortable with sharing that piece, that, there's an identified diagnosis maybe with the child, but then the stories are remarkable, what the families are living through. And now we have this overlay of COVID-19, and now the Black Lives Matter protest that
Right.
is bringing so much awareness to the world. So I'd love to hear your thoughts on that.
I would say the incidence of traumatized inmates is amazing. I mean, the number of people who struggle with nightmares, you wouldn't think, but these guys come in and I can't sleep. It's from stuff that happened in their recent lives. I was shot, my brother died in my arms, all of this stuff, but also about early things, sexual abuse, physical abuse, emotional abuse.
So we can think of trauma with a capital T, those kind of big kinds of events, like an event of abuse or an event of having a bomb go off or seeing somebody shot or being shot. So there are many traumas that we would call traumas with a capital T, but there are traumas with a small t. And I think that these traumas, we can call them micro traumas. They're the misattunements that continue to happen over time. So they can be the misattunements from the time one's an infant. And those kinds of misattunements, this is a more cumulative trauma that also has serious impact on the mental health and the outcomes. And some of those kinds of misattunements are set into motion because of misattunements around the body. Either the child comes into the world and can't be comfortable in their body and is never fully attuned to, or can't therefore it affects the attachment, or there's not a goodness of fit because of the different embodiments. So that this contributes to these cumulative traumas with a small t that also leave one isolated, feeling not understood, feeling that the world is a dangerous place because I can't get comfortable. So there are those kinds of traumas that really are under the radar and that affect mental health and affect relationships. And of course, you can also have traumas with a small t and then traumas with a large T that really are so devastating for people.
Yes.
It's very interesting because and maybe you can help me see if this makes sense on what you just said, Ruben, because I remember a story of a small kid who was like 2 or 2.5 years old, and the attachment with his mom was, was really a problem because mom was coming to the sessions and she would say, yeah, I just don't know how to relate with him and I just don't know what to do. And when we brought a psychoanalyst in and she helped them go through this. But what we figured out that this was not something that started like 2 years old or 3 years old. It was like something like started when he was unable to breastfeed because this kid was severely tactile defensiveness. Mm-hmm. And, it was avoiding constantly. And mom was feeling so depressed because she couldn't feel in the role of being a mom, and I don't know if this is this small t traumas, but it starts with small things that sometimes we don't think about it, and I don't know if that relates to that.
Absolutely, and we think of the interaction, right? So here you have a child that's tactily defensive, has difficulty nursing and probably difficulty feeling comfortable in mom's arms. And then mom could be feeling rejected or I can't understand my child. And then you have, as you say, this interactive cycle that builds on itself.
Exactly.
It becomes depressed, yeah.
Because it's, and we often in sensory integration, we look to the child, right? But then, it has an impact on moms and vice versa. And it's really interesting. And I had the chance to work with this psychologists and psychoanalysts that really get the SI piece, but the collaboration, as you said, it's so important, so interesting.
Yeah, so we talk about that too as transdisciplinary, not just transactional, bottom up and top down, but transdisciplinary. We have to be in good and humble relationships with other therapies and practitioners.
Well, one of the things that we've learned from adults with disabilities, people perhaps on the autism spectrum who are now able to express themselves, is that there seems still to be a denial of their sensory concerns. So by caregivers, like, oh, get over it, or you just get your clothes on, what's wrong with you, and interpreting it as behavior. And I love that term misattunement over time, because children may end up saying, okay, well, I'll just wear it, but I don't like it, and they keep telling, but somehow their feelings are negated over time, and they just either give up or they get angry. And I think that's where, Bob, like over time, then if stuff happens, those big T thing happens, or they end up blowing, like, okay, I've had enough, then they're identified as the problem, as opposed to the caregivers who negated their experience for year after year after year.
Mm-hmm. Caregivers, teachers, school districts, yes.
Yeah, and then try to behavior it away.
Right.
Yeah, that's tough. So what do we do? How do we help that? How do we prevent that? How do we heal the misattunements?
Well, I'm thinking these kinds of dialogues are such an important place to start. because my field needs to learn how to also see the way that the body plays into somebody's development and attachment, trauma history, sense of self. So we need that dialogue with occupational therapy, sensory integration practitioners. And I think it's important for OTs to be able to hear from us how important their impact is on the development of attachment, on a sense of self, on being secure in the world. And also on the goodness of fit between parent and child.
Mm-hmm. Well, and I know that it's happened to me a couple times where I'm in a session with a child and suddenly it's revealed that they have some of those things that Bob's talking about, that there has been some incidents of sexual abuse or observing something kind of horrific and traumatic. And I know as an OT, I feel like I can do a lot in the mental health field, but when I get there with those big, I'm out of my depth. And so what would your advice be to the therapy, our OT community? Where do we go when we sort of uncover or suspect these things?
So again, having good relations with somebody that's a therapist, you can ask them and then they can help coach what you might say to the parent. And this is one of the ways that we have these lovely cross referrals.
Mm-hmm.
I'll have somebody come in and they're being identified as oppositional defiant or something of that sort. And I'll see that they really need to be understood in their body. Or OTs will see that something is dysfunctional in the family or something's been revealed. And gently will help them introduce the family to the idea that perhaps you might want to consult with and with somebody in the mental health field.
Robin, don't you think that speaks to having a therapeutic alignment with the parents too, right? In a different way than maybe this is my treatment provider, my child works with them, and occasionally I'll get an update, right? That in some ways parents need to track along with you, and we develop that relationship and that level of trust so that maybe later on, if indeed there's a trauma, or let's say a parent is really struggling with depression, we have more access to not only hear about that, but to help them to the right person, right? I think a lot of those things will remain secret. Even in a very intensive psychotherapy model, it can sometimes be, and Robin, you probably can attest this, years, right? Where I've seen a child 2 times a week. I'll see the parents once a month, or even sometimes once every other week. Sometimes the parents come in our session, and years down the road, oh, I never mentioned this, but this happened. Right.
Yeah.
And I would never get that information if I didn't build that therapeutic alliance with the family. And if we look at supporting the child development, we have to support the family development. They can't do it by themselves. So I find a lot of value in including parents in my work when I can. And
yes, and that language of therapeutic alliance, that's really important for OTs too.
Yeah.
To look for opportunities to not just have a feedback session, but to build a rapport so that a parent might start to really talk about what they're experiencing at home and start to lean in to the occupational therapist as well.
Well, we have this term therapeutic alliance built into our fidelity to air sensory integration. I think we interpreted a lot about building that alliance with the child. I think it's interesting to think about expanding that then to the caregiver system, because you don't just have a child ever, you have the caregivers. So that's a nice extension of our understanding of that.
Mm-hmm. And Susanne, that's such a good point. That might be something we really should talk about more with the therapist. Occupational therapy as a whole tends to have a lot of young therapists, often therapists that don't yet have children of their own. And I know that, you know, when I was an administrator at a practice, I would sometimes, you know, be a little bit surprised at the feelings towards the parents, not quite fully understanding what was on their plate. And that might be a really good tool, this idea of that the therapeutic alliance needs to be not only with the child, but with the whole unit, the whole family unit.
I love that you brought up the notion of having compassion for the parent, because you know, there's such a tendency to align only with the child and be mad at the parent for not understanding, for being stressed and overwhelmed. But they might have children that are really dysregulated, and that's 24/7. It's not the 50 minutes that we see them in our consulting rooms. And to open up that compassion for the parents is also an important shift. Marco, yeah.
It really helps when you have children. I mean,
Your own children.
when your own children, it completely changes your perspective. And I consider myself a person that relates with others, not only children, but parents as well. But it completely changed the, you know, the way you see that how much these parents are doing, and they don't have your background, they don't have your expertise, they don't, you know, they just trying to do their best. And that's, but I love that these ideas of, you know, they just expanding it and bring more of this into therapy, SOTs and other therapists that work with families.
Yeah, our friend Joan Dostal is commenting that this has been one of the benefits of the teletherapy, the telehealth sessions, of getting to really see what, you know, firsthand in day-to-day life, what families are coping with. And we are always looking for those silver linings. But yeah, and I think, Marco, I think there might be some questions, but Bob, I didn't want to cut you out. It looked like you might have had something that you wanted to join in on.
Yeah, there's a question for Bob. I'm sorry, my internet went down. So Bob, someone is asking, it's an anonymous question. So do you see patterns in the clients you see that lead to certain people ending up in prison and others not following that path into prison? Is there something we should watch for to change that trajectory? What do you think about this? It's a big question.
Well, I think the presence of another person in somebody's life can be make an incredible difference. And I think that a lot of the people that I see, I continue to get the feeling that they don't have that person who was able to influence their behavior. And it gets back again to the families and the bonds that we're all talking about. I mean, I see a lot of people from very strong families, and they'll say that they're very strong, but sometimes you get the feeling that they weren't strong in ways that were important enough, I guess. But you know, if you have a mental illness and you get, I mean, the people in the MICA program, which Zoe mentioned, MICA is mentally ill, chemically abusive. And boy, if you have an addiction and you're also schizophrenic and you don't have any way of paying for your drugs, and I mean, the whole thing just gets so intense. But the quicker you can identify people with substance things or with mental things and get them the treatment with diverse treaters that they need. I mean, you really need to pick things up, you know, upstream as much as you can, and start working with all the misattunements, I guess.
I think that I like to say that I'm in the business of hope. So it doesn't matter at what age you enter in, but we have the hope that if there's a connection, it might only be one person,
right,
at a critical period of time. So we can't tell what is going on young and how that's going to look when they're older.
right.
because something can happen that it shifts the whole system. And you know, just kind of in the business of hope that maybe you could.
And things happen. I mean, the people who end up in our program, you know, they come there. There's like, I work with a really good staff of people, you know, social work and treatment, this and that, and we're their hope. And a lot of them really accept us and try to and learn a lot from us. And it's hugely inspiring to see somebody who's been incarcerated for maybe 8 or 10 years and hasn't really ever had any kind of attention to what their actual problems are. And I mean, I feel hopeful about that stuff all the time. I agree with you completely. You know, you need to keep one needs to be very, very hopeful and positive, but things do happen for the better and things do come true. Now or at some other point, you know.
If I were going to think about one factor that's really important, the one is the ability to tolerate, you know, to stay regulated when something occurs that's upsetting, when an idea comes forward that's upsetting. I've been meeting with a lot of study groups lately to keep myself in contact with other colleagues. And, you know, the ability to stay regulated, to tolerate frustration in the face of something challenging, that's a very important protective factor. And again, that's where sensory integration, OT, regulation, that's where that body-based piece is so important to understand.
And that's huge because, I mean, poor impulse. If I had to say one thing that's gotten most people into trouble that I come across, and it's poor impulse control. You know, it's just doing that thing you shouldn't have done, whether it was aggressive or criminal or this or that. It's not just thinking. It's like, I thought it, but I shouldn't have done it. You know, that's and it's an irritability thing. It's low frustration tolerance, and in the end, you do something impulsively that you regret for a long time.
You know, Bob and Robin, you probably remember the research, and it's probably 25 years at this point, when they talked about like the pathway towards maybe the prison system, and that was ADHD, oppositional defiant, conduct disorder, and then eventually kind of incarceration. I can't help but think, as practitioners, if we were able to look differently from a diagnostic perspective in terms of what we see in our kids, and to help them with those fundamental pieces, like Robin, you were mentioning, regulation, you know, support when it comes to attachment and trauma, that those, you know, I guess Russell Barkley calls them lagging skills, that those might develop in those kids and they might not end up in, you know, the justice system at some point. But it takes a very different lens when we look at kids that way, and when we're even from the get-go diagnosing them and helping to kind of support that development.
Yeah.
Courtney, I love what you just said, because you know, the research on mindfulness is so strong, and the application in schools, and rather than punishing children, go sit on the yellow line at recess or whatever, if they have incorporated the mindfulness programs, they find such fabulous outcomes with a lot of reduced disciplinary actions.
Mm-hmm. Yeah, what I was referencing wasn't Russell Barkley, although he's great. It was Russ Green's The Explosive Child. I don't know if anyone's read that book, but that's someone who has come from the justice system and discovered, probably along the lines maybe, Bob, as you have, that there are kids that are lagging fundamental skills, impulse control being one of the most primary. And how do we support those skills and develop those along the way, and how we maybe discipline kids, or how the school system suspends them or sends them home doesn't help that development. It never teaches them how to do better with what innately they've never had enough help with. So sorry to interrupt you.
No, that was great. We have a question here. I believe this is Kat Smith. She's asking, what about praxis deficits and impulsivity? The link between poor sensory registration to have the necessary feedback to use to inform feed forward? Is this
Wow.
something that could could actually be at stake,
Well,
right?
okay, now we're getting into technical SI stuff. So, but I think we feel like there's a link between those foundational body awareness, decision-making, motor planning skills, and the potentiality for planning. And of course, it sits in juxtaposition with those regulatory structures. So I would say that it's quite foundational to the building of executive functioning. It's not the same thing. Executive functions are in a different part of the brain, but certainly I think one supports another. Zoe, do you have?
I'm just looking at Bob. I'm wondering what Bob, what you remember about praxis and how, since you did a master's thesis on praxis, and we have this question and how much of that, comes to mind as you work with your patients and see their struggles. This idea that the lack of impulsivity, how much of that is lack of ideation and, knowing what to do, what are the possibilities of what to do?
I don't know if I can add anything more than what Susanne said, but I know that I think a lot about the patients that I first had in the school system. When I was the first year that I was an OT, and I think a lot about them and how they, when I see some of the people that I work with now, and I flash back on some of the things a little 5-year-old was, they taught him about fighting, and and he was explaining what they, and it was all like totally, it was like news to him. You're not supposed to hit people if you're mad at them. Oh, I learned that today. Like at the age of 6. Well, really, like I don't know. It's just weird. People are different, but I don't know exactly about praxis, so I'm not sure. I defer.
Well, it makes sense to me that without having these multiple action plans, because they're not available, that it's always such a strain, because always the top down is having to think of what do I do, and it doesn't have the underlying foundation of being able to in the movement sensing way organize to have some action plans, some ideation behind that. So it's extremely taxing as well.
And I think we often deal with it with a cognitive approach, thinking about practice, not praxis, but practice, yes, which is such a longer route to get to something than being able to actually feel it in your body and not have to use the cognitive structure so heavily. I'm just wondering, Marco, if you wanted them to try to get to that other question, but we only have a minute left. What happened?
That's what I was saying. We only have a minute, but we have a question, and maybe this is a good question to just sum all of this. And the question is, how much of trauma do you, and this is for all panelists, think COVID and quarantine is bringing, maybe? And how would you approach this with the families while on quarantine? Probably to avoid this trauma or avoid this, some problems that COVID and quarantine isolation can bring. Do you have any ideas? We're talking about masks in the beginning, Robin. Maybe you want to add something about it?
I'm just thinking, especially if you have dysregulated kids having to stay home and not having access to the kinds of things that help them stay regulated. And you have parents that are stressed and worried about COVID, but also stressed because they have to manage to get through a day, and then tomorrow is going to be the same. You just have this interaction of stress. And I think we have to think about, again, bottom regulation, self and mutual regulation. And it's really important for the parent to know that it's important for them to take care of themselves and to allow themselves the opportunity to be regulated and to bring their own stress down, because that's going to translate to these very sensitive children.
Mm-hmm.
Hey, well, the time always goes so fast. I can tell from the comments that this has been a really meaningful conversation, and one that I know others will be listening to and will get a lot out of it. So thank you all so much.
Thank you.
And
Thank you.
Thank
Suzanne,
you.
what are we doing next week?
Well, I was just looking that up because I never
Because you
remember.
knew
But
I was going to ask.
next week, we are very excited to have our Sensory Integration Research Collaborative joining us. And we're going to be talking about leadership in research. And it's a star-studded cast. Teresa May Benson, Anita Bundy, Zoe Malo, Mayu, Shelley Lane, Roseanne Shaw, Sarah Schoen, and Dr. Diane Parham, and myself. So our research collaborative will be here next week. But before we leave, I just wanted to make a comment because, you know, when you were talking about you need a person or a community that believes in them.
Uh-oh. Uh-oh, here she goes.
This is our community, you guys, all of you, you know, our partners at Centerpoint, old friends. Oh my God, there we go. Everybody who's joining us on these webinars, so many friends from here and all over the world. So cheers.
Cheers. And we
Cheers.
always want to remind everyone, stay connected, stay positive, stay safe.
There we go. Okay.
Okay, thank you so much for
Thank you
this,
all.
guys.
We'll see you next week. Whoever
Cheers.
can join us. Cheers.
Thanks everybody.
Bye.
Thank you.
Ciao, ciao.
Thank you.